Today we'll be talking about antimicrobial resistant Neisseria gonorrhoeae. We will be talking about it in the context of a differential diagnosis for abdominal pain or pelvic pain. Typical gonorrhea was mentioned multiple times in class briefly, but with this patient case, we can delve more deeply into the average patient presentation, as well as the issue of antibiotic resistance. Our patient today presents with abdominal pain and fever. JC is a 23-year-old cis female whose primary concern is her lower abdominal pain. She last presented in January for routine STI screening and was later treated due to an asymptomatic gonorrhea infection. She appeared for her 3-month follow-up and was subsequently treated again after a second positive gonorrhea result. At that visit, she stated that she and her partner may not have abstained from sex during the treatment period. She presents today with low-grade fever, dysuria, and cramping in the lower abdomen. Before discussing this patient's assessment, diagnosis, and treatment, let's first discuss background and epidemiology of gonorrhea. It was discovered in 1878 in France and was associated with genitourinary infection. Currently, it is the second highest reported bacterial STI in the US. The bacteria itself is gram-negative, and as you can see from the electron microscopy photo on the left, it is a diplococci bacteria. In 2018, the CDC reported around 1.6 million new infections of gonorrhea in the US, and greater than 50% of the people were ages 15 to 24. You are more likely to see an asymptomatic infection in a person who is assigned female at birth. This occurs 30% of the time and can lead to underreporting of STIs caused by lack of screening. Later on in this presentation, we'll discuss in more detail what a symptomatic infection looks like in both AMAB and AFAB individuals. Also, we will discuss more how this intracellular pathogen actually infects the host. Infections can be genital, pharyngeal, rectal, and even conjunctival. Infants born to parents with active gonorrhea infections are at much greater risk of gonorrhea eye infections and possible blindness. As for disseminated infection, this can be associated with purulent arthritis, as well as a triad of tenosynovitis, dermatitis, and polyarthralgias. In 2019, the CDC updated its list of antimicrobial resistant threats. We not only see that Neisseria gonorrhea is included on this list, but we also see that it is a top priority urgent threat. With this information in mind about gonorrhea, we still need to assess the patient fully and rule out other differential diagnoses. She has the known past medical history of gonorrhea infection, a father with asthma and a mother with hyperthyroidism, and a maternal grandmother with glaucoma. She takes combined oral contraceptives, vitamin D, and iron. Her only allergies are seasonal environmental allergies. Her current partner is a partner of 5 months, and though it is not written here, we would make sure to ask the patient about the body parts that she and her partner have, knowing that her partner may be cisgender, transgender, or gender nonconforming. She's a veterinary assistant, has a vegetarian diet, does not use tobacco products, and has 2 to 3 glasses of wine weekly. She has weekly marijuana use and exercises by playing soccer and swimming. As mentioned earlier, she is positive for fever. She denies chills, nausea, and vomiting, denies chest pain, shortness of breath, and is positive for urinary urgency, frequency, and dysuria. She does not get her menstrual period due to continuous cycling of combined oral contraceptives. Her physical exam is unremarkable, other than suprapubic tenderness. The differentials we are considering in this case are urethritis, including chlamydia and gonorrhea, pelvic inflammatory disease, acute cystitis, nephrolithiasis, and vaginitis, such as that which can be caused by bacterial vaginosis. Before discussing the plan for this patient and the diagnostic testing, let's first talk about a typical gonorrhea presentation. Signs and symptoms can occur anywhere from 1 to 14 days after exposure. In AMAB patients, or patients with a penis, signs and symptoms can include pain and burning when urinating, penile discharge, epididymitis, rectal discharge, anal itching, soreness and bleeding, and painful bowel movements. In AFAB patients, or patients with a vagina, signs and symptoms can include, again, pain and burning when urinating, vaginal discharge, intermenstrual bleeding, rectal discharge, anal itching, soreness and bleeding, painful bowel movements, and lower abdominal pain and dyspareunia. One very important thing to remember is that if you don't screen the right location of the body, you won't find the infection. In 2017, Fairley et al. Reported that in men who have sex with men, 58% of pharyngeal and rectal infections were not associated with urethral infection. This means that if only urethral screening had been done, the infections could have been missed. This, of course, applies to everyone, not just men who have sex with men, and it emphasizes the idea that taking a good sexual history is extremely important, including the types of sexual activity patients engage in. The gold standard for typical diagnostic testing is the nucleic acid amplification test. It does not allow for antimicrobial resistant testing, but the specimen can be collected in multiple ways: through urine, through urethral swab in patients with a penis, which is pictured on the right, endocervical or vaginal swab, rectal swab, or pharyngeal swab. The treatment is antibiotics, and we will discuss the antibiotics that have been used historically as well as the ones that are currently used. Patients should be instructed to follow up within 3 months, and they should get a test of cure nucleic acid amplification test. Culture and susceptibility testing are recommended by the CDC for any cases of presumed treatment failure. This is a wonderful slide by Quillen et al. 2017. The bacteria first adheres to the host epithelium through type 4 pili. The bacterial cells replicate, creating microcolonies that likely form biofilms, which are thought to compete with the host's natural microbiome. These microcolonies release fragments of peptidoglycan, lipooligosaccharides, and outer membrane vesicles, all of which lead to toll-like receptor activation and nucleotide binding oligomerization domain-containing protein signaling within dendritic cells and macrophages. Consequently, cytokines and chemokines are released and inflammatory transcription factors are activated. This pro-inflammatory signaling creates further cytokine and chemokine release, leading to recruitment of polymorphonuclear leukocytes to the infected epithelium. These immune cells phagocytose and interact with the invasive bacteria, giving rise to the purulent exudate that aids in transmission to new hosts. Now back to our patient. After doing the physical exam, we create a plan for today's date of service. We know that reinfection is still possible between JC and her partner, but we are nevertheless suspicious that antibiotic-resistant gonorrhea may be present. Of course, we get a routine chlamydia gonorrhea nucleic acid amplification test, and per CDC guidelines, we get a urine culture and antibiotic susceptibility testing. To cover our bases, we also get a urine analysis, and the results can be seen here. Before we discuss gonorrhea and its own specific timeline of antimicrobial resistance, let's first discuss antimicrobial resistance as a whole. This is a great CDC timeline that shows the year that an antibiotic was created, and then on the top, the year that a germ was found to be resistant to that same antimicrobial. First, we look at penicillin, discovered in 1941, and then we can see that in 1942, a strain of Staphylococcus aureus was discovered to be resistant against penicillin. Next, in red, we see that vancomycin was discovered in 1958, and also in red, in 1988, a microbe was discovered to be resistant. As you look at the timeline moving closer and closer to the present day, you start to see the time between antibiotic discovery and the date of resistant organism discovery is shrinking. This is why antibiotic stewardship is so important, because the less we overuse antibiotics, the fewer strains become resistant. Now, here is a CDC timeline of Neisseria gonorrhea specifically. We see sulfonamides used for treatment in the 30s and then no longer used for treatment in the 40s due to resistance. Penicillin then became the treatment of choice, but in the 80s, penicillin and tetracycline were no longer recommended due to resistance. In the 1990s, fluoroquinolones become the predominant treatment for gonorrhea. And then we see that in the 2000s, fluoroquinolones fall out of favor due to resistance, and cephalosporins become the dominant recommendation for treatment. IM ceftriaxone and oral Cefamex were both used, but then in 2012, Cefamex was no longer recommended. Azithromycin was then recommended, along with the ceftriaxone treatment. But in 2020, like so many other antibiotics before it, azithromycin was no longer recommended due to antibiotic resistance showing up. The CDC refers to ceftriaxone as the only remaining highly effective antibiotic for treating gonorrhea today. We give ceftriaxone intramuscularly at 500 milligrams in a single dose, and its mechanism of action is inhibiting the bacterial cell wall synthesis. So, back to our patient. What were our patient's results from their culture and susceptibility testing? They have a very, very rare case of cephalosporin-resistant Neisseria gonorrhea. Genetic testing of these types of strains has shown that the PEN-A allele is involved in the reduced susceptibility to extended spectrum cephalosporins and is linked to treatment failure. Strains like this have been identified in China, Canada, Denmark, Australia, France, and the UK. The very first U.S. strain was identified in 2019 in Nevada. Luckily at this time, azithromycin and ceftriaxone were still both used together to treat gonorrhea infections. The patient was treated empirically on this date of service, and the next time he was seen for follow-up, he did not test positive for gonorrhea, and he did not have any symptoms. Our treatment for today's patient would depend on the susceptibility testing. For example, if this patient's strain of gonorrhea was found to be partially resistant to cephalosporins, but not resistant to azithromycin, we would be able to treat them with azithromycin. It would be extremely important to follow up with this patient in less than 3 months and to report this finding to our city and state public health agencies so that they can do contact tracing and keep records.